exactly.
So
Where's that money going?
yeah, but you're telling me, can you break down like the cost of an unhealthy community and what that does for the state?
Yeah, so I'll start it. I'll try and break it down relatively quickly in terms of a couple levels. So when I say things like health disparities, it means that people have different outcomes based on where you live, what you look like,
Yep.
and I keep it very simple. That health equity means that you have the opportunity for the same outcome, which I think most people who engage in our health system want the same opportunity for
100%.
health.
Yeah.
Keep it
Or
very
why would you
simple.
be in healthcare?
Well, or why would right? Look, just because of where I live, I want this, I still want to have access to the same outcome.
100%.
There are a lot of conversations about that are ongoing about health equity and health inequity and whether or not that needs to be addressed. And for me, I want to speak people's language no matter what's going on. Some people say it's a moral imperative. That's one argument. Some people say it is a people imperative, meaning that when we're dealing with this, you, as a healthcare organization or institution, you attract more people. That's another thing to decide. I like math because it's super objective, and the state of Massachusetts, as well as Tulane University, both Tulane in 2018 and University of and the state of Massachusetts, I think it's 2023, both did studies on, well, okay, we know that there are health inequities in our system. How much does this cost us? State of Massachusetts calculated out it's 5.3 billion with a B per year for patients of color who are having unnecessary hospitalizations, increased mortality, death. 5.3 B with a billion.
Man.
Factor that now one state, okay, well, that's Massachusetts. What does that mean for Iowa? Taking the same logic and everything else, and this is my math, so it could be wrong a little bit, but I think it's directionally correct. The state of Iowa, that number is probably 8.6 billion with a B dollars. Now, people are like, well, you're right, it's not my money. Well, actually, it's your tax dollars, and it's the infrastructure that goes in to be able to care for all of those. Imagine if we redirected, and for Iowa, it is rural inequities as well as racial inequities. So if we were spending time thinking about where we're putting our dollars should be, for me, saying, you mean to tell me I can spend $8.6 billion less if we can eliminate health disparities in this state? Okay,
Man.
that sounds like a good plan to me, but that means that there's outreach into communities. It means it is figuring out how do you get to people that either can't access the transportation issue, or what do we structurally have to do to be able to fix that? But that is money that can be reinvested in so many other things. But to the point, you have to reach the individual patient, and we, both the state as well as systems like Unity Point, have to say, okay, well, how are we reconfiguring ourselves to meet the needs and help to reduce cost and get better outcomes? And the better outcomes are fewer people dying from preventable disease, period.
Period. And, and something that, you hear a lot, or at least I hear a lot, and I have said a lot, is trying to meet people where they are at. But, that is easier said than done.
Absolutely.
You know what I mean? That's not something that, oh, yeah, got to meet people where they're at. Okay. There has to be a whole plan to do that. I think it's important because, to your point, transportation is a huge problem. Even for somebody that you would think in Des Moines, which is not as, it's not Houston.
No, it's not Houston.
You know what I mean? But you would think that people would have easy access to get to places, but not everybody has that same privilege, right? I can get anywhere I want to within 15, 20 minutes. If it takes 30 minutes, I got a problem. But for somebody who's maybe 10 minutes away from a Unity Point clinic or somewhere, or 15, they can't make it. And then take into account, this is something that I don't think we talk a whole lot about when it comes to transportation, is I've seen patients who have transportation through their insurance. They have an appointment at 11 o'clock. Transportation drops them off at 8, so they're hours
Day.
early. Then they're done with their 20-minute appointment by 11:25 or whatever. Now they're waiting for transportation for another 3 hours. Do you think that person's going to want to come back for an appointment?
No, you're right. I mean, how, appointments can take forever because we don't have perfect transportation.
Yeah.
And forget perfect. We don't even have adequate transportation to be able to get people there, and respecting that how they're going to be able to do that. And to your point, right? We don't have a public transportation. We have public transportation here in Des Moines, but again, if I spread out throughout the state, I'm at Fort Dodge. We have patients that, if you're 30 minutes away from Fort Dodge, you're many times you're in a very rural community.
Mm-hmm.
If you don't have a vehicle, what does that mean?
Yeah.
How do we get you to get your screening? Because it's not that you don't want to go, it's you can't get there. And God forbid now you're waiting until it's a crisis that you can call the ambulance that you hope is there
Yeah.
to be able to come and get you. And so, yeah, I don't know that there's a perfect solution, but I think that part of the reason why, as a system, we track the social determinants of health for both our inpatients and outpatients is it's not because, oh, it's checking a box. It's because we're trying to understand at a population level how bad is the problem, and then how are we going to engage in saying, to your point, I can't solve everybody's problem.
Right.
But if I can solve 10% of the problem, we've made a difference. And maybe that 10% sparks the next idea of the next, and we're doing things like gas cards and other things to try and help patients get in and out of our hospitals and our clinics to be able to do that. But we're trying to be thoughtful in terms of that approach. But you're right, it's a massive problem, and it's a huge opportunity for us to engage with community partners as well as governmental institutions to try and solve for it.
No, I love that. I want to bring it back to the panel, the Black Men's Health panel, a little bit. Is there something that you're hoping that our audience maybe goes away with when we're talking about Black men's health, specifically here in Iowa?